I don't like coming to dentists. I think it's one of my least favorite places to come to. You know, every time you hear a dentist in a chair, you don't know what to expect. My name's Natasha Jacobi, and I am 35 years old. I suffer a lot from sensitive gums, and it bothers me, in the general hygiene of the mouth. Besides that, the fact that the top teeth, as you can see, they're not 100% straight, it makes me a bit conscious about giving the full, teeth smile, if I can say. So I normally would smile with my mouth closed. Being an adult, I didn't want to get braces because braces is, visible, and it makes you self-conscious. And so that was out of the table. And to know that I'm coming here today and getting a treatment done that's not going to be painful when I leave here or while I'm sitting in the chair is actually quite exciting for me. Every treatment that I looked in the past was quite time consuming. Also a painful treatment that would take a lot of effort from me and a lot of discipline from me. It is the most natural way of basically straightening your teeth without using, any of the ceramic that a regular veneer would do for you. It's a biomechanical product, and it's done in one session. So, I'm in here today and I'm going to walk out with a new smile, which is pretty freaking amazing, When I heard Dr. Lempel is in Cape Town again, I was like, okay, I'm going to seize the opportunity now. I'm not letting him go before I have it done now, and I'm just going to do it. I'm really looking forward to having this new smile and for this amazing experience. So it's been a week since I had my teeth done with Professor Lempel, and this is the result. I feel much more confident to smile with an open mouth. I can definitely say that. I'm very proud of it. You walk around like, you feel like $1 million, let's just say that. The day after, it was getting used to, a whole new kind of set of teeth. You do feel like you have something on it. It felt a bit like a plaster was put on the teeth. And now, as the days pass, I think neurologically your brain gets more and more used to the fact that something's changed in your mouth, and it's getting to look more and more natural, feel more and more natural. In the big picture, I'm very, very happy. I've got a huge difference. I've definitely accomplished what I wanted to, which is having straight, beautiful teeth and being able to smile, an open mouth smile without feeling conscious. The amount of compliments that I've got has been enormous. So if anyone is looking to get this procedure done, there's definitely so much more plus sides to doing it than any other treatment. It is cost effective, it is not damaging your natural tooth. So there's a lot of plus points to getting this kind of treatment done if you're looking for improving your teeth and your smile and your dental hygiene.
Hello, good afternoon to everyone. And I will now share my screen so that we can start. Welcome to our clinical journals, doctors. This is an exciting afternoon for all of us. I am Dr. Jean Galindez, and right now we will be discussing one case for everyone to see and be able to ask questions later. This is a way for us to really teach all of you how to address every cases that you might encounter in your clinic. And I'm very happy to present to you a very special guest. But before we proceed, I would just like to request certain things for the participants. So during the interview, because this is a different kind of webinar that we are trying to test to make it more engaging and interactive for everyone. So please do mute first your audio. And if you have any questions, please write it down on the Q&A if you're too shy to ask, or click the raise button, and you can unmute it, and Wong, my co-host for this afternoon, will address you and you will be able to ask questions. Okay, also, please do provide necessary reaction if you have one, and do answer our feedback by the end of this webinar. We would really like to know if this is something that you did like the way we presented it, because we wanted to have different ways of teaching and improving our profession. Okay. Now, this coming end of August and first week of September, we will have the last opportunity for an edelweiss workshop for everyone who are interested to participate. And later on, you may ask what are the requirements in order to join this for free. Now, the last opportunity, meaning you just have to purchase the advanced toolbox kit, because later on, the next trainings will have a fee. Okay, so let's proceed now of me introducing to you one of our special guests. And I'm so excited to introduce Dr. Eko Priambodo. He graduated from UGM Faculty of Dentistry and has been training for several years since he graduated up to 2001. He is currently the chairman of Indonesian Academy of Aesthetic Dentistry, and right now a private practitioner in Jakarta that concentrates on family dentistry and full mouth cosmetic rehab. Now, to explain to you, doctors, what we are going to do this afternoon, I will interview him, and he will present one clinical case that he has encountered, and you will experience like you are in the clinic, wherein we will provide you the diagnosis, how it is done, what is the treatment plan, and he will specifically concentrate on teaching you how to do a simple smile design that you don't need to spend so much money on in getting applications. Of course, doctors, if you have the money to purchase all these applications, you may do so. But he will show you a simple and effective way later on. Okay, according to him, as an ordinary dentist working in a small private dental office, this clinical case presentation, I put it as a tear-away sharing of my daily works when placing edelweiss veneer. Ladies and gentlemen, doctors, let me introduce to you Dr. Eko Priambodo.
Good evening. Hi, Dr. Chen. Can
Hello,
you?
doctor.
Hello, how
Hi.
are you?
Yes, I'm so excited that you are here.
Yeah.
Yes,
Me
you know,
too.
doctors, Dr. Eko is a very generous dentist. He often shares his cases with us, and we are very excited that he will show one case and allow you to really immerse on it. Right, Dr. Eko?
Well, it will be my honor. Thank you for the opportunity. And thank you for attending the and watching my slide and spare your time for all the doctor here
Yes. Dr. Eko, can you move your camera in front, because
in
I see
front. Let
you
me see.
sideways. Can you face? Uh,
It's just because of the situation of
there. It's okay.
the green screen.
we,
The
we
green
would
screen
like
is
to
not
see
working.
your handsome face.
Oh, I'm into that, doctor.
Okay, Dr. Eko, before we start, can you slightly or for a short period of time tell us more about yourself as a private practitioner?
Well, not much because I'm just doing anything at all, just like the same all of you. Not very fancy case. Just love to help people by doing a makeover by their smile. And this otherwise give me an opportunity to change their life in just only one day. As you can see, that minions is representing me because I have no hair. I'm just not as yellow as the minion. Dr. Jin, I give time for you to lead me.
Yes. So, doctors, we promise that after this, hopefully, within an hour, when you go back to your practice on Monday, you will be so excited to test and try to adapt anything that you have learned from this webinar. Right, Dr. Echo?
Exactly, exactly. I found it very helpful and very promising. So let's continue, doctor. I'll
Yes.
follow you.
So, this is your patient. Can you tell us more about your patient right now?
Right. This is Mrs. Arini. She's 52 years old. Actually, first he came to my office. She's complaining about the sensitivity on her upper front tooth. But during our talk, she interested in her appearance of her front tooth, and despite there's a sensitivity, he talked more and demand for a. She doesn't tell me. She doesn't call it makeover, but she just want to change the look of her teeth, especially the front one, and especially the lateral teeth, the tooth number 22. She feels so what you call it, feel annoying with it because it's a peck shaped lateral. You can see it. So and then we proceed. She had 11 and 21 teeth have been filled with the composite or with the previous dentist, and I found that I must do the root canal for the 24. Nothing else more about that, but yeah, I
Okay,
found.
Dr. Echo. So,
Mhm.
basically, it's the concern of your patient is
This is the concern of
aesthetics.
the patient. Yes,
Yes.
that's the word. That's the word.
So, there is dullness, and of course, there is a lingual I mean, more on the lingual palatal area wherein the lateral incisor
On
is,
the
uh,
lateral, yes,
yes.
yes,
And
that's right.
then you are currently doing a root canal
Yeah,
on
I'm doing
2-4.
actually on 2-4.
Okay. And then the patient doesn't want braces, right?
She doesn't want braces at all.
Yeah, me
Yeah,
too.
you too.
Okay, so so basically, that is the patient. So about my age as well, so I can relate.
uh,
So what is the diagnosis now?
so at first quadrant, you can find the attraction. Yeah, of course, you can find it in the fourth quadrant also, but our focus right now is not the cause of the attraction. You all know that the attraction most of the time is occur because of the problem with the partial occlusion. So since you want it change instantly, so I choose to use a edelweiss. By doing that, we can go for instant veneer or on the same day appointment in one day. This is my the second quadrant. You can see the pec shape and 22, 21 is procline, milk rotate, and caries mesopalatal. We had abrasion on 23 and 24. As you know, we are undergoing an endodontic treatment. I'm not putting any diagnostic record regarding other teeth condition because we only focusing on the upper anterior, right?
Yes. So, normally, Dr. Echo, it is common for older people to have fraction in their
Mm,
teeth, correct?
yes, correct.
And the peg shaped lateral generally before, if you try to treat it with composite resin, the tendency is you're going to do a cavity preparation, right?
Right. Similar like the cavity preparation.
So the first one is you have taken a lot of photographs, right? Is this something that you
Yes,
often do in your clinic for all cases that you take
all
photographs?
cases. All cases. I must say, I do all the cases. I make a photograph. I'm not doing it using a very fancy equipment since I don't use any complicated and fancy photography equipment. I'm just using a handphone camera because it's very efficient and fast also. And sometimes if I must make a picture like this one in the screen, I only use a pocket camera helping with help some small lens assembly in Indonesia. It's just very nice. Yes, it's too many blur and but it is okay as long as it can sufficient enough to observe and help me to examination the procedure. But to more better result, of course, you should consider to have a more sophisticated camera, doctor. But we don't have time for that. The young people
Yes,
have. The
yes.
young
I,
people
I,
have.
I actually invested in a lot of fancy
Ah,
camera, and it's
and
so very heavy, especially the macro lens. And then if you are treating the patient and nobody's gonna take the photo, then it is really more convenient, right?
it's so
To use
inconvenient
the
to use the
mobile
camera.
camera.
Actually, it is. It is. It is.
Okay, but the important thing, dentist, is that you really have to take photographs, not only for documentation, but for your analysis, right, Dr. Eko?
Exactly, and do not forget that we need to attach the photograph documentation also to complete our info consent. Sometimes patient is always forget what they have been done with the treatment, right? Please consider
Correct.
it.
And this is also very critical if the patient ends up complaining later. At least you have a documentation on how the process happened. Right, Dr.
Right,
Eko?
right, right.
Okay, so now we will proceed with the treatment plan. So we had the chief complaint, and then Dr. Echo took a lot of photographs, and now we will proceed on the treatment planning of this case. So, Dr. Echo, can you explain the treatment plan, please?
Yeah. First, plan to, as you can see in the screen, you can see on the screen, I will preparation for removing the old composite fillings and the restoration in cavities carried out in parallel with the veneer procedure later on. On the 22 reduce, I I plan to reduce the incisal length around, if I'm not mistaken, it was 1 millimeter or less because we don't want to ruin with the pulpa. And position of the veneer in such of a way that I must free the incisal area from the antagonist tooth, which is tooth number 33 and 32, right? If I'm not mistaken. So, and then I will continue to restore the abfraction on tooth 14, 13, and 23.
So basically, it's all just the anteriors with
It
a
is
root
on the anterior.
canal on the tooth number 24, correct?
Yes, yeah. And it's still under treatment.
Yes, and you have not involved the premolar because the way the patient smiles doesn't involve showing the facial surface of the premolar, correct?
Actually, I put one premolar on right premolar, Dr. Jade.
Okay.
It is on the right premolar, right upper premolar, only one.
Ah, okay. Because you're still going to treat 2-4 with root canal.
Yes, exactly.
Okay. So right now we already have the treatment plan. Okay.
Yeah,
And then
right.
there is also additional things that you wanted to
The
establish with
line, the
your
draw.
treatment plan. In
Yeah, with the
addition,
treatment plan.
in addition to it is also very important, Dr. Echo, that we establish the midline, right? Because sometimes when
So,
there is a malocclusion or a change on the alignment of the teeth, sometimes when we restore, it is off midline.
it's it happens all the time.
So this is what the lines represent, correct, Dr. Echo?
Correct.
Can you expound more on the lines that our dentists can see on the screen?
Yes, first, we must determine the midline. Of course, we cannot only rely on the papil and then make the trace the line vertically like that because I only rely on the frenulum and using straight to the interdental papilla on the centralis. After I decide to determine the midline, and then the second key point is to determine the what we call it, the smile line, the incisal smile line, and
Yes.
hoping that it could be parallel with the vermilion on the lower tooth, the lower lip. So you can see on the at the on the third picture, I put I draw the line there. I draw the line over there to give me some brief overview for where I must achieve or I must attain where's the line. The line gives me a direction to put the veneer later. And also, uh, I must consider the shade since she is not young anymore. I'm no offense, but she's 50 years old.
Yes.
It's so not funny if I put a very bright white color on her tooth, especially because we cannot proceed the veneer on the lower tooth, and because she refused to do the orthodontic treatment. So uh, I use color of A3 or something, A3 and B1, and blend it, and in hoping that someday it will reduce the shade will reduce a little bit, and then you can it will match with the lower tooth.
Yes,
So anything
because
that you want to ask about.
it's very important, Dr. Echo, that we build a symmetry on the face of
Asymmetry.
our patient.
Right,
And
right.
basically the guide, sometimes dentists tend to be not so particular in drawing lines, you know. But if you go to a lot of dermatologists or cosmetic doctors, they really draw on your face directly,
Yeah.
so that right, right, so that they
I
can
don't have that
visibly
experience.
visibly see what they are doing. And dentists should start really doing this, especially if they do not have a special application, right, Dr. Echo?
Exactly, doctor. Exactly. And it is
Okay.
very, very easy application. You can only take your PowerPoint or your Keynote if you use Mac or iOS, and there is a drawing tools there, and you can use it as long as you know you understand the concept, and you can do it in only 30 minutes. To me,
Yes, this is
it's
one of the
it's
steps
easy.
a lot of dentists, Dr. Echo, try to
Skip.
skip. Yes. And as you've said, you just use Keynote, took photos, and
Yes,
draw
yes,
lines so that you
yes,
can visually see what
yes,
you are going to do with the patient, correct?
yes. Correct, correct.
Okay. So, just to briefly show the difference, because sometimes, Dr. Echo, dentist tends to get confused with the attrition, abfraction, erosion, and abrasion. So currently, your patient has abfraction.
Abstraction.
Yes. So, so here you go. Uh, when you are trying to now sort out what you are going to do. So can you try to explain, Dr. Echo, what this photo means in terms of smile design?
Okay, my first step in what not designing the smile actually to drawing the outline is to establishing the proposed tooth position. It's to indicate the general parameter upon which to apply the proportion teeth. So we begin with placing the vertical midline. It's a must. It's mandatory. This sets the stage for the center point of the face and the smile, and it gives more orientation for us put the to position the rest of the veneer. And next, you should outline what I call a smile line. The second step is draw the smile line.
The
As you
white
can,
wine, the white line. Yes.
the white line is the
Okay.
smile line.
And then the green one is the midline, right?
The green one is the midline, and
And the
not to
blue
forget
ones,
the blue one is I
the gingival height.
the gingival zenith. Yes,
Yes.
actually, it's the gingival. But I'm not force myself to achieve a gingival symmetry because it's patient had a very lower lip smile. What we call it that we cannot see the cervical area when she smile when she took smile. So I just leave it there and not bother to go for to undergo the gingivectomy procedure or something like that.
That's
Since I
why
also see
uh,
on
that's why,
ask for
Dr.
1 year.
Echo, it's very important that you take a photo of the patient smiling, correct? So that
Correct.
then you can see whether the gums is showing when they
Right.
smile, or the premolar is also showing, because that's how you really
Yeah.
start your treatment plan, right?
Exactly, doctor. Thank you. Yeah, yeah, you get me well.
Okay, so here you go. Can you explain also the other references?
Yeah, this uh, vertical line represent the what I call the axis of the not really axis, but it's the axis is to this to give me the not a direction, a key point, a reference where I can put the tip of the tooth, the tip of the gingival contour, the zenith. It is very important when you placing veneer, and also when you must reshaping the cervical area, and so you can see that the particularly you must see particularly on the tooth number 22. I cannot establish to yes that one. You see, this is so tilting digit to distal, and tooth number left canine tooth number 23. Just cannot forget it. Tooth 23. It is very challenging, Dr. Jane, because it's too bulky. It is also so wide, and I need to make some reduce on that area, on the distal area, to make more space so the veneer can available go insert in between the 21 and the 23. You can see from the next slide, maybe.
Yeah, so that is why you are doing this, so that you will know which one you will
Mhm.
have to add and which one you're going to reduce, correct, Dr. Echo?
The position,
Yes.
how to, yes, we wanted to get the position of the tooth, of course.
Okay, so this is the next slide.
Yeah, so you can see that uh, we want to know where are we presently, so we can plan more and proceed with the position of the tooth. This outline only give me, especially to me, give me a brief, rough idea uh, where I can and how I must position the veneer later, and it will affect to the design of the preparation also, right?
Yes. Okay, so here you go. That's why it's
Hmm.
very important, Dr. Echo, that we really have the photo, right?
Yeah, it is really, really important. So after that, these three lines, you can see the midline, the smile line is the white drawing, and the gingival symmetry, hopefully a little bit gingival here. Ah, yeah, the template, the outline template. You can go back to the previous slide, please, Dr. Jane.
And
Yeah, on the lower.
uh,
Yeah, exactly.
I need to exit from the bigger one so I can move and show
Sure.
to the. Okay, so it's like this, right? So
Right. So, yeah,
you
thank
drag
you.
it like that,
I drag that and adjust
and
the
then
as long as you can maintain the constraint, doctor.
you try to control the proportion of this, right?
Yes,
On your
yes.
drawings.
That is the exact proportion with the sizing chart. Size. I took it from the sizing chart of the edelweiss. So don't worry, it's the same proportion with edelweiss. As long as you still maintain the constraint proportion on your laptop, on your computer.
Yeah, so what Dr. Echo is trying to say is that he did everything this planning on just Keynote. And then you use the template of Edelweiss, correct? And
Correct.
he told me that you just click this constraint proportion so that if you increase the size of the tooth, that
Yeah.
you're in order to figure out if that is the right size for the case, the proportion will remain the same. Correct, Dr.
You
Echo?
Yeah, I can add that it gives me a better perspective on how I must position the veneer. You can see that we must add some area or reduce some segment and so on and so on.
Okay, so on the next slide is, can you explain more?
Yeah, okay. Centrals is always the actually the hardest part on placing veneer. Not to mention the porcelain, especially when we don't want to reduce so much enamel on the tooth. And if we go see this case, I try to maintain the procline of the proclination of the tooth number 21 because we cannot do much with this tooth. And I told patient that we accept that we cannot make those both centralis in symmetrical position. She doesn't mind about it. She didn't mind, and then I continue by, if you can see that, Dr. Jane, you
Yes.
can resizing the centralis,
The
the
central, yes.
outline. Yeah.
Because what Dr. Echo is trying to say is that in real life, when we are cementing
Right.
any veneers, correct, Dr. Echo? Like
Correct.
me
Correct.
personally, I really cement first the two centrals, right?
Yeah.
Before I proceed with any other tooth.
Oh
so,
yeah. Yeah. Definitely.
so what do you want me to do with this central?
Uh, on the tooth number 21, Dr. Jane,
Okay.
you can resize it and decrease it, make it smaller. Right. Right. Exactly. Again, Dr. Jane, can you do it again? Can you make it more? Bit more. Proceed, proceed. So by doing that and drag it a bit lower, you you can see that we must reduce a little bit on the distal segment, on the distal area. Imagine that this size of the edelweiss. I'm not worried about the proportion because edelweiss is always in the exact width and length, general universal proportion. What you call it? Universal proportion or something. What I need is only I have a rough idea where to put my edelweiss on the central.
Yes. Doctors, the thing is, what Dr. Eko is trying to say is by doing this in your keynote, taking a photo, trying to take time to analyze what you need to do, you are able to see which of the area of the tooth you need to reduce, or
Right.
if you
Exactly.
can also choose a smaller size of the veneer, and this you can do even if you are not using edelweiss veneers, correct, Dr. Echo?
Correct, doctor. Thank you. Thank you very much.
Yes, and on this photo.
Yes, on this photo, you can see the tooth number 22, doctor. I must tilt it more to the mesial, right? Because it is not possible to put it like that.
Okay, so by playing with this kind of planning, you are already able to see which of the parts that you have
Which
to
of the part that we have
reduce,
to
right?
reduce, right?
In order to create an illusion of the
Yeah,
alignment of the tooth, correct?
exactly, correct.
On this one,
That's the sample of the sizing chart of the edelweiss, right? On your left side of the screen. And it's just to show you, showing you that the edelweiss is fabricated in a very uniform, good proportion. But the gut of edelweiss, Dr. Stephen Navarro, is 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 already anticipating to us to more flexible in doing. It doesn't matter if the size is too big for the tooth. You can still always resize it by doing some reducement after the placement. Myself, I love to do it after the placement, doctor, not before, after the placement.
yes, because you can actually see how it really looks like.
Overall,
Uh,
yeah,
doctors, what is really nice about a device, because I've been using it for more than 15 years already, and I have it on my lower teeth. What is so nice about a device is that because it is preformed, and if you do
yes,
what Dr. Echo is trying to show you, to visual your patient. You can also do a try-in directly on the patient by
of course,
using a expired composite and just
yes,
paste it so that you can already see if you are getting these lines properly. Correct,
right,
Dr. Echo?
correct. And also, it's a very good marketing tools also, doctor, before the
Yes.
patient feel confidence.
And we cannot do that if it is already done in the laboratory, right?
No, 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 no. It is impossible, of course.
Okay, so now you have this is the sizing guide where
Right.
Dr. Echo patterned his drawings, correct?
Yeah, but I'm sorry. This is actually it's not the picture of the same patient. But I hope I mean the message is the same. I hope you don't mind, though.
So by drawing, doctors, having the photo of your patient, and by looking it visually, you can already see which is the best size for you. Would you like a smaller one because you're going to reduce the tooth structure, or a bigger one because you are trying to reshape the alignment, right, Dr. Echo?
Oh well, Dr. Jin, the determining the decision of the size, you must take the sizing chart, like the sizing guide here, and put it over the tooth, and then you decide which size that you will take. The S size, the L size, or the M size. The outline in different matter, it help us to see the proportion, but not the size, only the proportion and the perspective. If you can help me to clarify this.
Okay. So here, this is already you're trying to apply your treatment plan. as you've
Yes.
said earlier,
Uh,
you remove all the cavities and then did the preparation of the
yeah,
veneer.
you can see tooth number 22, doctor. I must do a butt joint design preparation because I need to cut a real 1 millimeter of the length of tooth number 22. But the rest of the tooth, I try as minimum as possible to reduce the enamel. And if you can see, I'm not used to work with the gingival retraction, the cord. Because of the structure of the gingiva, the scallop is good in good shape. So I'm just following the scallop and then let the edelweiss do the rest.
Yes,
Did
so
you understand what I mean?
by removing all the affected area,
Ah,
you have like this one, you have really reduced the canine because earlier in our photo, this is quite
it's
bulky.
so quite bulky.
Yes. So now that you did the preparation, you are now
Mm.
going to show them using of silicone dye material instead of creating a cast, correct?
Correct. So after doing the smile design outline and to be able applying the smile design outline, we need to create the 3D model, right, doctor?
Yes. So I will just continue talking, Dr. Echo. I will just show them
Oh, cool, cool, cool.
what is the silicone dye
Mm.
silicone or why how it's done so that
Mhm.
you know. So this is a lot honestly, doctors, even if sometimes we do not want to spend so much on our capitalization, but there are procedures that makes the extra expense worth it, right, Dr. Echo? Instead of
Exactly,
the
doctor.
messy cast tone and the flexibility and the inaccuracy sometimes with using the stone, this will allow us to really manipulate well what we are doing. So just like what Dr. Echo will show you later, he also took a alginate impression on the patient and used a silicone dye to create the
A model.
replication
Yes.
of the actual case so that he will be able to manipulate it well. Now, on this video, what you can see is that the dentist used a Lego in order to hold the disilicone. But with Dr. Echo later, what he used is a putty, right?
Exactly. Okay, the PK,
Yes.
polycylindrical kind of.
Yes, and what is very nice about this disilicone, and just like if you arrive in in the webinar earlier, there is a video wherein Dr. Stefan is also using disilicone in order to create a one unit bridge for occlusion VD. And this is very good technique to be able to do an indirect restoration quite comfortably. See, so like sometimes Dr. Echo, right, we wish that we can remove the tooth and restore it and then put it back, right? You are in mute, Dr. Echo.
Yes, yes,
Yes.
exactly.
So, but
It's a lot,
disilicone
lot
will
more
be
easier.
able to make you do that, right? It's like you
Exactly.
take out
Take
the tooth structure and is able to uh,
put it again
do the
and have the contact.
restoration. Yes. So that is how it is done. And this is the same thing as what Dr. Echo did. Okay, so Dr. Echo,
Yeah,
so at least we've shown them how disilicone is
great.
it's a
Thank
part
you,
of
doctor.
your treatment.
Thank you
So
so
go
much.
ahead.
So
By the
after
way,
we put, yeah,
excuse me, we got the request from a dentist saying that is it possible to make it to the full screen so that they can have a
Okay.
better view?
Because
Yeah.
earlier I cannot adjust the tooth if I do not put this in this one. Okay, so I can zoom it again. Okay, go ahead, Dr. Eko.
Also, instead of I think the Lego is the, I just don't have, I think I'm going to use a change to use the Lego thing,
Yes,
Dr.
it's
Jane,
it's
right?
cheaper. It's
It's
cheaper, right?
cheaper. And always can be reusable. Okay,
Yes.
so here's the putty. The blue one is the putty. I mean, the impression material, and I put it over the disilicone before it's setting, so it can blend and grabs one into another. So after we have this die model, you may see the planning on where you want to put the veneer or following with the outline. So you put the veneer on, you put the edelweiss on to the surface on the labial area of the prep. Continue, doctor. This one, I have the video, but maybe later I can give you. There's one missing thing here, right? So this is the template. So if you can see the blue arrow is the line for us to allow the light curing go inside and make the spot curing method. And we remove the template, we remove the positioning guide, and we can still removing the composite because it's not polymerized yet. It's
So
very
you,
easy.
Dr. Eko, you created this ditch, right? This
The
ditch,
ditch, yeah.
so that when you spot cure it, this is in the area where the light will pass through.
Yes, yes.
Okay. And then after removing it, then you are going to clean the excess
The excess
and
of the composite.
before you fully cure.
And I'm not worried anymore about the thickness and the sometimes the composite it could be so slippery if we lose for the pressure hand, and then the composite will move and the veneer will move also. So it's so annoying. That is
Yeah.
why we need to do the spot curing. Definitely we need the spot curing.
Yes. And in order to do that, they have to create this ditch.
The ditch, yeah.
Yes. Okay.
That button is the result of the ditch on the incisor, on the incisor area. That small button. So we continue clean the excess. Continue clean the excess. We are not worried the veneer will moving.
Yes,
And then
because
this
you
is the final
already
curing.
spot cure it.
Yeah.
This also lessens the time for finishing and polishing, right, Dr. Eko?
Of course, definitely, doctor. It is, and the result is very good. This I'll show you when the tooth number 11 is still messy with the composite around the tooth. I still need to remove all the composite, the excess around the veneer, but it is easy to remove it because it's not polymerized yet.
Yes, yes. A very nice technique. And also, you already have a guide on how to position it. So
Yeah, I do.
so it is not gonna be malpositioned and you prevent that mistakes, right?
Right, right, doctor. But sometimes I need help to marking it. You can see the spot mark there.
Yes, and please explain to our dentist this red dot that you created.
Well, yeah, doctor. As you can see, the mesial wall, the mesial margin on this tooth number 13, it's very tight with the ejection tooth. Somehow, I find it hard to just directly place the veneer on it. So what I'm doing is I put the veneer on the position that I prefer. So, and then make some dot from the using a street or what we call it, the pencil marker, and then put the composite on the intaglio area, and then just put it back again, and then voila. This is it helps so much in the position, doc.
Yeah, sometimes these little things are really critical, like our timer for the bonding, these
Yes,
dots, this dye silicone,
right.
and this will really help you remove the chances of making mistakes and wasting material
Exactly.
and your
Exactly.
time, right?
Exactly, doctor.
Okay, so
So,
here you go, Dr. Echo.
so as you can see on the upper, on the above is the plan of the outline. And on the lower is the after we do the placement. You can see tooth number 11. Edelweiss is the what you call it, the green line dot line is to represent the proportion of the exact edelweiss. But in the reality, we must reduce the edelweiss and the veneer to achieve the slim and straight square shape of the tooth number 21. Yeah, I will show you later how we can reduce and reshape the line angle. So the upper is also the plan, and you can see the after on the lower. You can see that the tooth number 22 well fitted in, and but I must sacrifice the position of the shape of the tooth number 23. It's not according to the plan. It's split out from the plan.
Yeah, but
So because it must
considering,
compromise to give more space for tooth number 22, doctor. And
yes,
also, we didn't want to also to reduce more enamel on the tooth number 23, right?
correct. And by doing this, you are still able to create an illusion without too much reduction on the tooth
Yeah, that's what
structure,
happened. That's what
right?
happened. Yeah,
Like for
exactly,
example,
doctor.
in peg shape, as I've said, you create cavity if you want to rebuild it with composite. But with
Right.
Edelweiss, with the proper planning and positioning of what you did, Dr. Echo, the reduction is more on the canine, correct? Because,
Correct, doctor.
yes. And then you
Correct.
just increase the bulk of the lateral peg shape.
Exactly. Exactly.
Okay?
And now, as you can see from the plan and the after, I managed to get the parallel smile line and refine the midline and the mild rotation of tooth number 11 and tooth number 21. But the most important thing is now patient had what I call a long square veneer, not the bulky and rotate like the one before.
Yes, and look, it looks so natural. See, this is how in the front and in the back.
In the front and the back, yeah.
Yeah.
You might take a very close look. I want to emphasize the composite works well on the back lateral shape there.
Yeah, so normally, dentist, when you have cavities, you filled up the cavities first with composite, and then that's the time you cement the Edelweiss
Yeah.
veneers. Okay, so here are the tips of Dr. Echo. I know there are people who are raising their hands, but I'm truly sorry. I'm not able to. I'm the one manipulating the slides. So we will address it because we are almost done. And the point is, Dr. Echo is providing you how he has done this case, and you can ask questions afterwards. Okay, Dr. Echo, the first tip.
The first tip is to have a darker set on the cervical area. So what I'm doing is not to overfill it until the level of the margin. So I just make a small ball and put it there, and you can see that white arrow that shows you the I spare some more space to let the composite fill the space. If I'm not doing so, the composite will blend too much each other from the darker and the brighter, the bright value shade, and it's not good. So I cannot gain the cervical dark shade. Just don't overfill, and
So
then press the veneer firmly.
this is how you multi-layer it, right?
Yeah, doctor. Yes, yes. And tooth number 11, you can see the darker shade on the cervical.
So as you can see, Dr. Eko also putted pencil guidelines on where to reduce it and
And do
finish it,
some
right?
refinement. Yeah.
So that prevents over reduction or under reduction, right? And you are
You know,
guided
that's the root. That's
exactly
the root.
where you should reduce, right?
Yeah, right. That's the root. That's considered as a root. So here, I'm not really satisfied with the shape of the veneer immediately after I do the placement. So I make some marking again to the area which I where to the area which I want to reduce more and reshaping it. Please click the slide, doctor. I use the 3M flexible. We call it soft flex. It's a soft flexor to
So you have
refine the.
added transverse lines, curvatures to add more character on the tooth structure, correct?
It's more like I refine the line angle, doctor,
Yes.
to make it more look more slim.
So you actually reshape the tooth so that it will look
Yeah,
really natural with right characteristics in
yeah.
addition to what you already have on the edelweiss veneer itself.
Yes, that's it's the great thing about the edelweiss. We have the flexibility to to change our mind. You know,
Yeah.
we design it ourselves. And do not worry about the glosses or the polishing. It's so polishable. It's easy to polishing it. It is this show that that's proof that I grind there, I polish there, and then I refine, I reduce here, I reduce there, and still at the end of the day, I still can get the glossy, fascinating surface from it. This is the after.
Yes, I really looks beautiful. I mean, the patient is probably so happy with the result.
I
So
hope
this
so.
is the before and this is the after. Now we can really, I think a lot of dentists are so excited to ask questions. We've been seeing a lot of raised hands and question. Now we can now proceed with the Q&A. Go ahead, Wong. Wong?
Dr. Jin, you want me to read
Yes.
it out?
Yes.
Yes.
The
Yes.
presentation is
Okay.
over for the case, and so
Okay.
we can already handle the questions that they are so excited to ask Dr. Eko.
Yeah.
Go
Okay.
ahead.
First of all, Dr. Eko, I have a dentist with anonymous, and he asked May I know what make doctor to choose edelweiss veneer instead of direct composite veneer? As we all know that you are already a master in freestyle
I'm
restoration,
not
right?
consider myself as a master. So I
Based
should
on your very many years in the practice, and that's why I myself also have this. Question in my mind since long time
Mhm.
ago. So it is a good question for you actually.
Oh, thank you. Thank you. Appreciate it, Bang Wong. Well, anyway, Edelweiss give me a chance to the opportunity to change someone's life just in one day. And the second thing, in one the good thing about the marketing is that the patient doesn't have to wait any more longer than 2 hours. Most of the cases I've done it in 3 hours lah, max. 3 hours max. This case it took 3 hours because I need to spend more time to this to make the outline. So uh, when the patient has the spark, this is the marketing thing. When the patient has the spark of having a veneer and bright white good smile, that's the time I can go in with the edelweiss, not the porcelain. Then I just grab the opportunity, and then there they are. We have the new smile just after 3 hours. That's a great thing. The second thing is I can always reshape the veneer, not the tooth, the veneer. Not to mention that we can go for the minimal invasive because composite done the rest of the thing to feel the preparation, the lack of the preparation, and especially when I'm having a bad day and doing not a very good preparation, I'm not worried because otherwise working together with the composite that we use, and then the composite will fill the area that I'm not doing the preparation properly. I think that's the answer, Pao. Not to mention the result is super. The result is super.
Uh, can,
Okay.
can I also add into that? Like as I've said, I have my lower teeth made of edelweiss, and soon I have my rest of the upper teeth done. And as like Dr. Eko mentioned, as a dentist as well as a patient, you appreciate the natural tooth structure to remain in your mouth. And with composite, although it is also minimally invasive, but in order to put it on the tooth, you need to do preparation, right? With edelweiss, if it is not necessary, because on Dr. Eko's case, there is a reduction because of crowding and lingual inclination, and also there is Dr. Echo, right, on the bite, wherein there is the lower incisor is going to hit when the patient bites. That's why you need to do reduction, correct?
Yeah, correct, doctor.
Yes.
So
And
should I continue to the next question?
yes. So that is why it is minimally invasive, and
In
that's why I too prefer Edelweiss. Go ahead, Dr. Wong. The next
Okay.
question.
The next question is any tips to help reduce tooth width of anterior restoration? And I have some cases that have chief of big tooth and even change line angle still doesn't help much. Thank you.
Okay, there's two tips. First, I try to converge the not only the line angle but also the wall of the mesial and the distal. Just imagine like this one. And using the soft flex is very helpful. You must try it. The second one is I try to extend the embrasure, so we can have the more feminine and more slim tooth. The third thing is I put the eyes, draw a line on the loop area from the intaglio of the veneer, and it will create the illusion that the tooth is longer. Do you understand what I mean, Dr. J?
Yes, you
Can you
because
help me?
dentist, when you are trying to reduce the width of the tooth, okay, what Dr. Eko does is that he uses this ice tint at the back of edelweiss and place the ice on that area. So if you are using an edelweiss translucent, automatic when the light hits it, the ice will reflect a certain line and it
Right.
will look narrow than what it is actually. Am I getting it
Yeah,
correctly,
yes, yes,
Dr. Echo?
yes, yes. Very correctly. Very good word, doctor. Thank you so much. It was very helpful. It's been so helpful.
Yes.
You've been so helpful.
Wong, next question.
Yes. Awesome work, Dr. Eko. I wonder
Thank
how is
you.
the functional eccentric anterior relationships of veneers with lower teeth? And I got the message, private message. Is it going to be stable?
Well, it is going to be stable. Why? Because I
Is
don't,
anterior relationship, lower anterior need adjustment, I guess.
well, lower anterior need an orthodontic treatment, actually. If if we don't undergo with the orthodontic treatment or something later on at the end of the day, and if I cannot convince the patient to go for the orthodontic treatment, so our veneer actually will be failed and it will be ruined someday, some maybe in 2 or 3 years, right? The occlusion is not good, so I have a responsibility to a moral responsibility to motivate the patient to refine the occlusion. But before we proceed, or she can do the treatment that we suggest. Meanwhile, she can always enjoy the chewing and the occlusion as she had before, because I do not touch the incisal and palatal area. I don't even reduce the incisal area except the tooth number 22. Maybe it could answer the question. Maybe you can clarify it,
Yes.
Jen.
It is like this, doctors. Okay, there are cases like myself that I have diastema, right? And my chief complaint is just diastema. Okay, but my occlusion is not good. So, what Dr. Echo is trying to say is that currently this is the chief complaint of the patient. And since he is such a competent dentist, he suggested to the patient to have orthodontics. Okay? Because that is really the best way to correct any alignment or occlusion problem. But the thing is, the patient doesn't want braces for the meantime. So what Dr. Echo did was give first what the patient want and try to relieve this area, okay? And hopefully after 2 to 3 years, or even in a matter of months when the patient comes back, I think because Dr. Echo is doing a root canal, right?
Yeah.
So Dr. Echo can continually ask the patient to do aligners in the lowers. And then, of course, because what is good about Edelweiss, he just remove the tooth structure that aren't necessary. Because if you have this done with porcelain, then you would have prepared it and you have, you know, there's useless in doing, orthodontics later. But because Dr. Eko used edelweiss, the majority of the tooth structure on the upper are still there. Right, Dr. Eko?
Right, right, doctor.
Okay. So, Wong, any other
Okay,
questions?
the next question is, in the last case presented, is in the last case presented, I think midline could
It's
have
just
been
one
mashed
case, so
a
there's
bit
no last
more to
case.
left. How would you advise regarding this case?
Much. Can you translate me what is the meaning of
Okay,
the mushroom? Do you
I
mean
read it again.
that
Yeah.
shifting it
I
to the
think,
left, more lefting?
yes, I think the dentist is asking that you could have moved more the midline a
More
little bit on the
to
left
the
side. What do you need to do?
if well, I did correct it, but uh, I strictly try to stick on the tooth number 11 and on the mesial side. uh, I don't want really to go too far to the left or to the right, since it doesn't really obviously seen and it didn't affect too much about the appearance. As you can see, if only the midline goes too far over than 4 millimeter or something, then people will notice it. But if you can draw a straight line vertically from the granulum to the papilla of the centralis, we can always see not really too much obvious. So I can still also maintain the the cleanliness of the papilla and the surrounding cervical area. Yes, I can agree with you, doctor. It also can be done to move a bit the midline to the left. Yes, that's a very nice suggestion. Thank you very much, doctor. Very much.
Wong,
Yes.
next
Okay.
question.
Okay. Dr. Eko, thank you for your presentation. May I know the reason for doctor to place tooth two in edge to edge with the antagonist instead of placing it into class 1 position? Thank you, doctor.
Well, Doctor Wei, it's too thick. It's already too thick. The thickness. Uh, I cannot. I'm worried with with the what's called it, the gingival area. If I make it thicker on this on this cervical 22, it will trap the food somehow. And I don't know if the patient can maintain the and taking a very good care on this surrounding gum. But I try not to make it more thicker. That's the reason, doctor.
And Dr. Echo, I don't think you put the bite edge to edge. As you can see on your upper,
It's
when
still
the
free.
patient bites, it's not edge to edge. It is only on this part, on the lateral incisor, that is slightly touches the lingual surface of the
The
central.
surface of the central.
Yeah.
Yeah,
I don't think
it's
you
free of the
place
tongue.
it edge to edge. Yeah. Go ahead, Wong.
Okay, the next one is doc, when we need to use the gingiva retractor to make sure the veneers can go into sulcus well.
Well, when anytime actually you need to use the gingival retractor. It is a good tool, and it's also covering the gingival liquid. But I just not using it in this case because I did prepping it super gingivally. I prep
Yes.
it very careful, so I don't think I need it in this case, doctor. Only in this, but on other case, I will urge you to use the gingival retraction cord. It's very helpful.
Yes.
It's very
May
helpful.
I add into that? When it comes to edelweiss, you have to cement it supragingivally, not equi, not sub. So you don't really need gingival retraction unless you're using zirconium, Emax, Uh, but with edelweiss veneer, it's basically a little bit supragingival. Yes.
Yeah,
Okay.
yeah, yeah. And also, Dr. Jin, I want to add that Edelweiss has an what to call inward curve margin
Yes,
in it, right?
the
So
the
it functions
cervical
like a
end. Yes,
plus plus five stools matrix, something like that.
yes. And remember, doctors, we are using a regular composite to cement. And composite resin is hydrophobic. So we do not want anything underneath the gums because this will cause gingival irritation. Okay, Wong?
Yes. Yeah. I think that's all so far for the 6 questions. As I
Wow.
also mentioned over the chat that the show doesn't end here. It will still continue. We have our group chat, WhatsApp group chat for the users. Feel free to join and then ask questions 24/7. We have our experts across the whole world, the different continents. So you will get your questions answered 24/7. Yeah. And by the way, Dr. Jean, we also have another good news regarding the announcement of
So
our competition, right?
the cooperation.
Yes. Now I can.
Yeah.
Before we proceed, let's thank first Dr. Eko for
Thank you,
sharing
Dr. Jin.
his case with us today. And we hope that the dentists are able to get something or a tip that they can use in their restoration.
Oh,
I think they are
It
able
is
to
my
do
honor.
that. Thank
It
you
is my
so
honor.
much, Dr. Eko.
Thank
And
Dr.
you.
Jean, Dr.
yes,
Jean, Dr. Jean,
yes.
sorry, there are another 2 questions.
Okay, go
Okay,
ahead.
another 2 questions. Okay, hi, Dr. Eko. Thank you for the beneficial sharing. I would like to ask whether the veneer will be easily dislodged
Dislodge.
if patients bites on harder food, even though the occlusion has been relieved a bit, but when patient bites on thicker or harder food, will the veneer last?
But when the
This is
patient
actually a
bites
very
on,
common question that I always answer.
well, the veneer will broken actually. So you
Yes.
need to very, really, really careful and take a very, very good examination to the occlusion. It will break. What even if it's a zirconia veneer, it also will break.
Yes. When there's a problem with occlusion, that's it.
That's it.
Right, Dr.
Bye
Echo?
bye.
It
That's
does
it and
not
bye bye.
matter what the material is.
Should
Go
I
ahead, Wong.
directly continue the
Okay. You have a question from your colleague. I think you know
ah
her,
yeah.
Dr. Rebecca Mutiara from Indonesia.
Hi, Dr.
How
Rebecca.
long do edelweiss veneer last? And how about someone if they still smoke
No problem,
red
doctor.
wine, coffee, blah, blah, blah? The
No,
color
no,
will be
no.
changed soon. This
It
is
will
also
not.
another common questions that I always have to answer,
Really,
easily
really.
answer.
Well,
Yeah.
well, I've proven it. My first Edelweiss veneer is in 2012, and he is a public figure, and it's it didn't discolor at all. Yes, it's a bit rough and need more polishing, but it doesn't discolorization. But doctor, please do be very careful and it concern your patient not to drink or eat turmeric. In Indonesia, we call it kunyit. You know, the one that you eat with curry or something. That's a very a very yellow material. The turmeric. Is turmeric the right name for it?
Yes, turmeric.
Turmeric. So it will it will affect. It will change the color in the interproximal, but not on the surface of the veneer.
May I also add into that because, as I've said, I have
Yeah.
edelweiss in my lower, and doctors, I'm ashamed to admit I'm a chain smoker. So, and my edelweiss has been installed 2016, and the nicotine stain can only be seen on the natural tooth. But I never had the stain or nicotine stain on the edelweiss itself, and that I can tell you. That's 2016 up to current.
By the way, Dr. Jane, maybe we can also clarify with the precautions, as we have also got many dentists complaints about the staining and because
The
of
stain,
some
the stain.
extra steps that they have done. So maybe you can clarify on all this.
Okay, I will have to clarify. The stain is not on the edelweiss. It is on the composite resin that you use as cement. So if you have a leakage, even micro ones on the area, or let's just say you extended the cement in order to, fill up the remaining gap of the edelweiss. Let's just say if the edelweiss is too narrow for the face of your restoration, and you have to add composite, the composite will sting, but the edelweiss, it will never sting. And that, as I've said, I can honestly tell you, since 2016 it never stained on me. I drink coffee, I love cigarettes, so so I know it doesn't stain. Okay, Wong.
Dr. Jane, also, right, as you have also forgot to mention about the polishing protocol. You remember that there were a few dentists that came to us and said uh, they actually polished the surface, which was not necessary.
Well, you just have to buff it like what Dr. Eko did. You just have to buff it with goat hair brush, or, just to remove some of the dirt that sometimes get into the restoration. Right, Dr.
Yeah,
Eko?
Exactly, doctor.
yeah. Do not over polish it, right?
Do
They
not
can
over
over
polish it.
polish it because it will still gloss, just like what Dr. Eko said earlier. He
Okay.
has remember the video, this one, he drilled it because he wasn't happy with the shape. See, he drilled it, and then after polishing it, still the same, right, Dr. Eko?
Exactly, doctor. You can always polish it, no problem. That you cannot do to the porcelain.
Yeah. Even zirconium, it's so expensive to get a special burr. Yeah.
Yes, yes, yes.
So,
Okay. There's another question. Dr. Eko, can we use bonding with another brand, or we have to do it with otherwise bonding agent?
We need a veneer bond to bond the veneer to the composite. For the bonding agent for the dentin, you can use any brand at all. Any brand at all. I use 3 brands on to the dentin. But from the intaglio inside area of the edelweiss to the composite, we need to apply brass a veneer bond. It's a silent. It's not a bond. Silent. Silent.
yes,
Silent.
silane.
How to spell it? Silent.
Silane.
Right.
Yes. The
I
veneer
learned it
bond
from
is
Doctor.
not the veneer bond in
The bond.
Edelweiss is not a tooth bonding agent.
Bond.
It is a silane to bond the veneer into the composite. But your tooth bonding agent, you can use whatever tooth bonding agent you have.
Yeah. Yeah.
Yes. Actually, I have another question which is on the chart room.
Okay.
On
Okay,
the
that
chart
I
room.
overlook. Doctor, what kind from Dr. Jeannie? Doctor, what kind of adjustment should we make to make this composite veneer to stay long?
What
Any
kind of
relief
adjustment?
occlusion to be done? Thanks.
Yes, yes, Dr. Jane is greatly answer and describe that question. Yes, don't force ourselves to do a veneer, a porcelain, a ceramic, a metal, or even a composite when your patient have a potential occlusion problem. No, that's a no for the veneer. That's a no, the big no for the veneer.
Wong, somebody is raising his hand.
Okay.
Dien Hardiani.
Okay.
Do you charge it
Sorry,
lower
I
with
also overlooked another question.
do you charge it lower,
Dr.
right?
Angela, she
Yeah,
asked,
doctor.
do you charge lower with this than a porcelain veneer? I mean, in terms of the fee that you charge.
Yes, definitely, Dr. Angela. Well, edelweiss is not a competitor with porcelain. It's not supposed to become a head-to-head competition between edelweiss and porcelain. Uh, Belum ada saingi. There's no competitor for the ceramic until now. But yes, to be fair, I charge edelweiss much lower compared to the porcelain. Since also I don't need any material to support. I, I don't need too much material to go for edelweiss. I just need the bonding, the veneer, and the composite, and the tooth of the patient. At the end of the day, I need the invoice to be filled. I mean, the patient must pay, right? So
May
it's
I
very cheap.
also may I also add, Dr. Echo, you
Yeah,
can charge whatever you want. And
yeah,
just to clarify, Edelweiss is not a composite veneer. It is a vitrified glass, laser sintered vitrified glass made of barium glass and strontium glass. Its raw material came from composite, but it is not a composite. What is a composite is the cement. So that's why it doesn't stain, because it is glass and it is totally different from componeer. Just to clarify, because I time and again dentists gets confused and think that Edelweiss is a composite veneer. It is not a composite veneer. It is laser sintered vitrified glass. Okay, and you can charge whatever you want. It really depends on you. Okay, Wong.
Yeah, also I would like to clarify, regarding what you guys mentioned about the veneer bond. It is actually not a bond, it is more a silane. So for dentists that have got this veneer bond, which is a silane, it is actually a multiple function. You can use it to repair your PFM crown as well. And in fact, I have to clarify that otherwise doesn't really provide any bonding. Yeah, and you guys can use your own bonding of your choice, right, doctors?
Yes. Okay.
right.
Yeah,
So
because I have to admit that otherwise they should change the name
yes, it gets confusing.
to
Wong, there are
another name
three
instead of mentioning it as
participants.
veneer
Wong,
bond.
there are three participants
Yeah.
raising hands. Four
Oh yeah,
now.
yeah, yeah. Sorry, I could not see them. Hold on, yeah. Uh, how
You
can I
go
know?
to the participants because
Okay, okay. Dr. Chut Tien Hadiani, I can allow you to talk now. Dr. Chut Tien Hadiani, would you like to say something? You are allowed to. You are allowed to talk.
you can unmute him, or ask him to unmute.
Um, yeah, I've already unmuted. Um, okay, maybe we can go to the next one. Dr. Ranga Diputra, you can also allow to talk now if you want.
Hi, thank you for the opportunity. Sorry, but this is not Dr. Ranga. I'm with Dr. Ranga. This is Dr. Ari. I'm Dr. Eko friend. Hi, Dr. Eko, how are you?
Since you are the one who's do the asking, not really. I don't feel.
Sorry, I'm using Dr. Ranga's account because I can't log in. I have
I
a
don't
few
feel.
questions regarding edelweiss. Since I'm doing ortho, can we bond bracket on edelweiss? And if we can, do we need any special adhesive?
Well, doc, the special adhesive would be the veneer bond, but how effective this could be, I don't have any experience because what I'm Dr. Jen will refine me. What I'm suggesting is doing go for the clear aligner, doc, but not put the braces on it.
Okay. So even if we use clear liner, for example, is there any maximum force that allowed to move the tooth with edelweiss?
Yes, sadly, I don't know how much it is, but yes, I do. I do read that kind of information.
Okay. Okay. Thank you so much, boss.
And may I add
Glad you
with
stopped the question. Yes, please, Dr.
with
Jane.
the question of Dr. Diputra. One is that if you're just going to do orthodontics and if the patient is willing, then just go ahead and do orthodontics. And then you can apply edelweiss later for aesthetic reasons, not anymore on the alignment. I think with Dr. Eko's case, uh, the patient didn't want ortho. That's why he
That's why we
did
go for the
Edelweiss.
otherwise.
Like me, I did not want ortho. And as you can see, I actually have a root canal that is going to be treated later with Edelweiss. So I do not want ortho as well. So that's why although as a patient, I have to understand that if it breaks because there is a problem with my occlusion, then it is my fault and I have to change it because that's the way it is. If you're going to place any restoration and the occlusion or the functional occlusion is not established, then any restoration will get damaged sooner or later. So that is something that you have to emphasize to your patients if there is a problem with the functional occlusion. Edelweiss does not replace orthodontics. What it does is that it can become an alternative option if the patient really doesn't want orthodontics. Right, Dr. Eko?
Exactly, so exactly.
Okay.
It's that is why we call it instant ortho, right?
Yeah. Because
Yeah, yeah.
ortho will always answer the occlusional
Yeah.
occlusion part. So
Obviously.
it's just an interim. Like myself, I don't want ortho. I'm 50 plus years old. So just like the patient of Dr. Eko. So what we are doing is increasing my bite. So there is enough space to correct the occlusion via uh, Edelweiss CAD-CAM. Because I'm
Oh,
happy with Edelweiss, honestly.
that is good.
I mean, I'm a consultant, but I really believe in their product. Go ahead, Wong. I think there's another
Yeah.
one racing.
We
Doctor.
can also call that as a fake orthodontic. I
Yeah.
used to make a
Fake
Yeah.
joke with
ortho.
that.
Dr. Ranga, I think, go ahead, Dr. Ranga. This is why we are doing this because we really want interaction from all of you.
Okay.
Okay. Thank you so much. I think clear enough for me. Thank you so much, doctors.
Yes, your work will always be the best when it comes to occlusion and correcting the bite.
Yeah. But by the way, I just now I noticed Dr. Nancy Yu Obedoza.
Yes,
She
go
raised her
ahead,
hand.
Dr. Nancy.
Yeah. If you still want to ask any question, please feel free to do so.
And yes, and also Dr. Dien, he has been raising his hand the entire
Yeah.
lecture.
You are allowed
He is allowed. I
to
already
talk.
give
Just
permission.
unmute yourself.
Yes, just unmute.
Maybe no more.
Okay, so
No matter what, right? Even if you are unable to express yourself here, please feel free to join our WhatsApp group, and you as I said, you can post any questions there. yeah, after this, and I'm sure Dr. Eko will be able to answer.
Yeah, anytime, doctor.
Yes, and so let's now proceed with this has been a contest. Dr. Echo, so thank you so much for
Thank you
the
so much.
participation. We
Thank you for your
really
helping.
appreciate it. Yes.